I'm Grace. For anyone who does not know me, I am a nursing student at the University of Colorado in Colorado Springs. And I have with me today Liesl Wyka, who is not
Hello.
only a seasoned family nurse practitioner with some very cool experience in not only nursing but and nurse practitionering and providering, but also a plethora of other things. And she also happens to be, by some stroke of luck, my mom. So we're going to talk a little bit today about her experiences with rural health. And I found myself asking her a lot of questions about rural health and her experiences with that, and just thought that this would be a cool conversation to share. So, do you want to go ahead and sort of introduce yourself just briefly? I'm going to ask you a lot of questions, but who who are you?
Sure. Besides being your mom, which lucky me,
Be me.
I am a family nurse practitioner. I've been an NP for 12, almost 12 years. Um, Also graduated with my BSN as well as my MSN from University of Colorado, Colorado Springs, Bethel. Shout out to Bethel Accelerated Nursing Program. Um, I have practiced in quite a few settings over the last 12 years. I've worked in urban environments, but have really mostly been drawn to rural communities. I've worked in Southeast Colorado. I've worked at the border in southern Texas with detainees and immigrants, and currently I'm working in Hana, Hawaii, which is considered to be one of the most rural towns in the Pacific.
Yeah, and I will I'd love to kind of to dig into how some of those places are the same and how they're different, but just starting out, just since I know you well, but people who are listening might not know you quite as well. How did you get started in nursing? Did you intend to go into rural settings, or did you kind of find yourself drawn that way? Where did you start out?
Um, it's a great question. I have wanted to be a healthcare provider since I was probably 2 or 3 years old. Since I could talk, I told everybody I wanted to be a pediatrician and thought I wanted to do pediatrics, pediatric nursing. Once I got into my clinical rotations and had 4 kids, I was like, maybe there are some other specialties out there that I might want to consider just for various reasons. I've
Enough
also been a
kids.
teacher, so yeah, so also a degreed teacher, and so I love working with kids. And currently, actually, is that's what I'm doing, school-based health. But um, so the the nurse practitioner route fit very well into what I wanted to do. I didn't start that route until I was probably 40, maybe in my 40s, and was a nurse for a couple years, but knew that being a medical provider was what I really wanted to do. I, in my teens, worked in a little clinic in Papua New Guinea next to a Danish nurse for a while, and just love working with the underserved populations and their unique set of um, issues and their unique communities.
So, since a lot of us, in my peer group at least, are starting out now, just starting out our journey as RNs, and some of us are kind of starting to look at what the next step on the nursing sort of hierarchy would be, and looking at going the nurse practitioner route. Can you touch a little bit on kind of what the main differences are between kind of a general RN and someone who's a nurse practitioner, kind of what it means to be a provider versus um, a nurse and how that's different from maybe a physician or a PA or these different
Sure.
specialties.
Um, so as I'm sure most of you already have figured out in your nursing clinical work and your nursing experience so far, it's really all about scope of practice. Um, Nurse practitioner is cool because there are a lot of specialties. You can become board certified in family medicine, adult medicine, gerontology, pediatrics, women's health, women's care, emergency. There are a couple other, PMHNP, so the psychiatric mental health route. So in essence, you can become a specialist, much like a physician can. Nurse practitioners right now are fighting for independent practice in all 50 states. So unlike nursing, nursing has compact states, and I don't know how many there are now, but once you get a license in one state, you can be a compact nurse and travel, work across state borders and all that. With NP, you have to be licensed in each state. Um, as far as the differences so NP school is bachelor starts out as a bachelor's of nursing and RN, and I have to keep my RN current as well as my FNP license. Starts out as experience as an RN before you can get accepted into an NP program. Um, and depending on your specialty, 2 to 3 more years of clinical and didactic um, instruction. And then, of course, you take the national boards, just like kind of the NCLEX. But the scope of practice between a physician and a nurse practitioner is kind of blurred. I know that any physicians watching this are probably going to, give the eye roll when I say that our roles are very, very similar. We diagnose, we come up with a plan of care, we treat all conditions, chronic, acute, urgent. Um, as a family NP, I see brand new babies all the way up to, I've seen the oldest patient I've seen, I think is 101. So, um, procedurally, we function the same way. In rural medicine, we function much the same way.
So it's kind of, is it fair to say that maybe differs a little bit from hospital to hospital and area to area, the things that you might see a nurse practitioner doing versus a physician or another I know we were laughing recently because some of these medical shows don't have a very good grasp on what a nurse practitioner does, and they'll flip-flop between showing them as they're either a surgeon or they're functioning like a CNA or
Like a CNA.
an
Yeah.
LPN. Yeah, yeah. So it
Yeah.
seems like
Right.
culturally, how new is the NP program? I guess I'll have to look that up, whether it's
Oh,
or
I
the
have
certification.
actually, that's a great question. And I believe it actually started in Colorado. Um,
Hmm.
but unfortunately, I am not prepared to answer that question. I don't know.
No,
Want to
I don't know
say
the answer
I
either.
want to say like really fully started in the 80s, probably maybe even a little bit before that. But as far as board certification and all that, it's been around for a while, more and more popular as physicians are leaving medicine. So kind of stepping in the gap, I want to say. Um,
Mhm. Yeah, yeah. So you mentioned how these compact states, how with RNs you can move around maybe a little more, but did you say that you have to be like licensed per state
I do.
as an
I do.
NP?
I do, yep, and it's a full process. Everybody needs all the verifications and the licensing and all that, as well as all fees. So, like I said, I have to be registered as an RN as well as an advanced practice nurse in any state that I want to practice in. So currently I'm registered in Colorado, Hawaii, New Mexico. I've been registered in Georgia, Florida, Alabama. Um,
Sampling.
yeah, and so,
Yeah.
with NP, just I'll say this really fast. I know we need to move on, but NPs right now are fighting, like I said, for independent practice. We prescribe. I have my DEA, so I can prescribe controlled substances. I don't that often, but I am licensed to do that. And the sticky thing right now is there are red, yellow, and green states. If you look on a map of nursing practice, advanced nurse practice, a red state is NPs don't have a lot of autonomy. They need a physician oversight, just like a PA. PAs right now are also fighting for independent practice, but do not have independent practice. I don't think yet in any states they need physician oversight all the time, which they function just like NPs. So um, yellow states we have a little more autonomy, but still need physician oversight. There are certain things we can prescribe and can't prescribe. And then the green states are independent practice states, and those include, I think we're up to maybe 25 states
Oh
or
wow.
maybe more now have independent practice authority, which means I can hang out a shingle, have my own practice, and don't need physician oversight. So, a lot of physicians are against that. A lot of
Mm.
rural health centers are very much for that because of the shortage of
They need the
qualified providers. So
people. Yeah.
yeah, so I would say, states like Massachusetts, New York, places with very large medical facilities like Johns Hopkins and Harvard and NYU are not independent practice states yet. I think very much there's a lobby out there who would very much like to keep things separate. So, and just like anywhere, you have good physicians, bad physicians, good NPs, bad NPs, you know.
Yeah. So the color designation, the red, yellow, and green, is that an official um sort of a rating that a state will get, or is that sort of more a colloquial?
It's a map. I mean,
Oh
you can
yeah.
look it up under Independent Practice Authority for nurse practitioners, and that map will pop up showing you in red, yellow, or green the
Okay.
practice authority that the states have, that the NPs have in each state.
Yeah. So to kind of segue into rural health and kind of what that looks like and your experiences with some of that, just going off of kind of going back to the idea of nurse practitioners in these rural areas maybe functioning at a higher level. And I've also in a lot of the literature there are kind of and just stories that people share, there are a lot of reports of people in these areas having to really step up and fill in a lot of gaps. So I'm curious, just sort of about how you would define a rural health area. Like maybe that'd be a good place to start. What would you how would you define a rural area or a small hospital? What do these I'm sure that there are official sort of criteria that these places have to meet maybe with
Sure.
populations or
Yeah, it has to do with population. It has to do with access to larger medical centers. It has to do with uh, number of Medicaid and Medicare patients that we see. That one is a pretty big factor.
you
The
see
number of
more generally
Medicare and
or
Medicaid
fewer?
patients that we see. The majority of patients we see are uninsured. We say uninsured, underinsured, and then Medicaid, Medicare. A lot of them operate on like a sliding scale. Economically disadvantaged. Um, and like you said, I know that there are official designations. I took some notes here, so if I look away from my camera for a minute, um,
Yeah.
you know, kind of looking.
Yeah, because I mean I'm sure at least in the research, the little bit of research that I've done, it seems like the funding that some of these places get is tied to their status as one thing or another thing. Um,
Right. Yep. There are a couple designations. There's a rural health center, and then there are FQHCs, which is a federally qualified health center. And the FQHCs have quite a bit more stringent requirements. They have to be staffed a certain amount of time, I think 32.5 hours with a provider. You have to have somebody available 24 hours a day if you don't have a critical access hospital within a certain place. Whereas like just a rural health center, it's a little bit more um, uh, less stringent, I guess. They can be for profit or they can be nonprofit or public. FQHCs are always nonprofit or public.
and so do those look different in terms of does an FQHC versus a rural hospital or health center, do those look different in terms of population um or area, or is it
So
just
a
sort
rural
of more
health
the
center,
size?
yeah, so a rural health center is pretty strictly rural. I mean, it's pretty strictly in a rural area, farm community, or just a more remote town. FQHCs actually can be in an urban setting as well. You always
Hmm.
think of FQHCs as being in, a little farm town, but an FQHC can also be in an urban setting with a place where there are provider shortages, where um, um, there are a lot of underserved populations, which you might guess like in an inner city.
I know with inner cities they in like a nutrition sense they talk about food deserts. So I would imagine it's sort of
Yeah,
a healthcare healthcare desert maybe in
sure.
some of the same things. So
Yeah, and
you're
access, you see people who don't have
yeah.
cars
Yeah.
and don't have internet and even don't have phones. And, so a lot of times there are outreach programs here in Hana. I'm currently working in Hana, Hawaii. There's a mobile clinic that from time to time went out in a just like a clinic van kind of thing and took care of people. I know that there are similar programs in the inner cities with trucks that, serve as mobile clinics and food trucks.
Yeah. So can you tell us a little bit about Hana specifically? What just about the area for someone I had the privilege of being able to go and visit and shadow you a little bit and see what you did, but for someone who has never been there, what is it like? What is Hana from just a person's perspective, not even a healthcare
Sure.
provider?
Um, well, it's a beautiful rainforest jungle, full of beautiful flowers and fruit and vegetables growing out of everyone's ears everywhere. Um, as far as the community goes, it has a pre-K through 12 school, and they always laugh and say everyone is related to everyone, and that is not probably completely untrue. Very remote, separated from the nearest hospital by about 2 hours of the Hana Highway, which has something like 56 one-lane bridges and something like 600 curves or something like that. And Grace, you've driven with me on the Hana Highway, so you
It is
can
no joke.
attest
It
that
is
it's
no
no
joke.
joke. So,
Yep.
um, just getting back to the healthcare aspect, providers who are here have to really be prepared to be ER physicians and urgent care physicians and primary care physicians and pediatricians and yeah, so access, but it's such a lovely community. People really watch out for each other. Um, they love their keiki. They love their kids. Um, there are, you know, a couple cool beaches. The high school here has a surfing team, and um, the little kids paddle out on the bay, and it's just a beautiful little community.
And so the people that you're serving, it sounds like it's a really kind of a um tight knit kind of community where I would imagine there's a lot of probably community support between people. I mean, are there a lot of sort do people have good social support and family?
Yeah. So, people, a lot of people move to Las Vegas and move back. Um, a lot of people, live with, if there are any kinds of, family things going on or financial things going on, everybody has aunties and uncles and cousins that they all socialize with, live with, hang out with, very, very family oriented. The interesting thing in the whole mix of community here is tourism. We have a zillion tourists coming and going every day because the big thing is to drive the Hana Highway, so they hop in their rental Jeeps and drive the Hana Highway and, come here and do adventurous things. I was going to say stupid things, but, adventurous things and end up with lacerations and infections and, centipede stings and sea urchin spines and sea cucumber, squirts in the eye and all kinds of things like that. So,
Yeah.
we do see uh, a number of tourists, not as many as you would think, but like I said, again, you know, critical access. The clinic is staffed 24 hours a day. We have somebody on call, a provider on call 24 hours a day, as you
And
also
that's you.
witnessed.
That's you a lot of the time, right? So
It is.
so you'll be called in sometimes at 2 in the morning for a
Yeah, a baby who can't
surfing
breathe
injury or
or
a
yeah, yeah. Yeah. Another cool thing we have here in Hana is school-based health clinic. And it's not, a lot of people are like, oh, you're the school nurse. But the school-based health clinic is actually on the campus of Hana School, and it is actually a clinic. It is basically a pediatric clinic, but we see anybody's staff or kids. The parents sign a consent at the beginning of the year, and the kids can come. If they're sick, the teacher can bring them and get treated at the little clinic. We have a little dispensary with antibiotics and different little creams and things right now. Yeah, we're seeing a lot of sports physicals and things as the wrestling and surfing and softball season gets underway.
So I know with your what you're doing there, do you have a hospital? You don't have a hospital in Hana.
We do not. Nope. Like I said, the nearest hospital is 2 hours across the Hana Highway. We do have medevac. We have a helicopter that comes from Kahului, which is the where the hospital is, Waluku, Kahului, across the island. And we do medevac people a fair a fair number. I don't know if it's once a week or sometimes more than once a week. So, the first responders, we have one ambulance and some absolutely fantastic paramedics who are really skilled and, need to be out here. We have no women's care. We have an OB, a GYN who comes, but we have no prenatal care, no OB here. So, pregnant women, um, either who, if they don't want to drive to the other side, they don't have the best prenatal care, or they, once you get to the end, like when you go for weekly appointments, a lot of them don't because, again, they're hugely pregnant. It's a 2.5 hour drive across a dangerous highway. And so they fly over to Kahului and stay with auntie or, you know, um, grandma or whoever on the other side with a week or two of their due date so that they can make it to the hospital. And we have a lot of home births here.
Do you see, is that kind of a theme? You have that experience in Hana, but I know you've worked at some other pretty remote rural areas like Lamar and down at the border and these other places. Are there
Yeah,
are these sort of things that you see in all of these places where there's kind of a limited access to, that's one of the main problems, or what are some of the similarities that you've kind of seen, challenges of being a
sure.
sick person in these areas?
Yeah, I think one of the challenges is in rural communities, everybody knows everybody, or everybody's related to everybody. And so HIPAA can be a little challenging because, the office staff knows all the patients who come in, and then they kind of know what's going on, and it's hard to keep things private sometimes. I think that is one of the challenges here.
So
Um,
that might prevent
so
someone
they
from coming in to seek care because they don't necessarily want everyone to know that they're sick with one thing
absolutely,
or
yeah, no,
wow.
absolutely. A lot of times the story they tell the front desk is 100%, 180-degree difference from what they end up telling us when we're in the room. So
Oh wow.
that's one challenge. But Hana, as opposed to like Lamar, Lamar has a little critical access hospital right next to the clinic, and they have a clinic there that has specialists. We can send somebody across the parking lot to OB, or we can, I think they have dermatology, they have an orthopedic clinic. They have a number of specialists, and also I think maybe I'm not sure how many beds, 12 beds maybe, or something like that, and an ER. So we don't have call. I believe the clinic over on Molokai also has a little hospital nearby, so there's no call there as well. Like I said, Hana is remote. I mean, it's considered um, one of the most remote towns in the world, maybe even, I don't know, and at least in the Pacific, in the US for sure.
There isn't even
Um,
a coffee shop
so
there. That was what amazed me when maybe it was
I
closed,
know.
but maybe I missed it.
I was gonna say, I think there's one, Damin Bean, but it's not,
I
it has
mean
limited
Dean.
hours. Yeah, it's a food truck,
Yeah.
coffee truck. Um, uh,
So there are
so,
some areas
comparing,
that are maybe
oh, go
rural
ahead, sorry.
that have oh no, I think I'm lagging a little bit, but some of these rural areas, it seems like there's a lot of variety. Some might have a little more, and some are literally you have one person there who is your person. I have to just I mean that the thought of that is a little scary. I have to imagine being the on-call provider um is a little nerve-wracking if you're the only one in the whole town or the only one Hana side who can help someone if they're really in trouble.
It is, and I'm not the only provider here. We have a medical director who is a DO who works. She's in this clinic about 2 weeks a month, and then goes to Molokai as well, a couple 10 days, maybe a month. And we have another nurse practitioner, and often we'll have another locums physician. Right now, we have one that's leaving in May as well. So, I mean, if we really, really get in a bind, we call the paramedics. Often the paramedics actually are the ones who call us in the middle of the night and say, "Hey, I've got you know, whoever, an 86-year-old with, chest pain. Can you meet me at the clinic?" And so, um, we meet them up there, and they're there for support. And that's great because it's pretty hard to run a code by yourself. Um, but yeah, I mean, if we get in a bind, I can always try to get a hold of one of the other providers um, for support. Um, and so let me talk about provider retention in
yeah.
rural areas. Um, it's a major issue. Um, every rural FQHC underserved population clinic I've ever worked in does not have stable staff. I mean, the support staff generally are local people because they've been trained, they're MAs, CNAs, RNs, and the more education they have, the fewer of them there are. But it's a great way for people to stay in their community and be able to work at the clinic, and their husband has a job wherever else in the community. And so, having people who are trained, there's not as much turnover of support staff. But man, it's hard to keep providers. I'm telling you, it is hard to keep providers at these clinics. They're almost always locums. The longest locums uh, period is like 6 months. 3 months
So,
is more typical.
so that means they're bringing in new people every and
New
locum
people every 3 to 6
means they're
months.
coming from
Yeah.
wherever they're coming from and
Yep. Oh
doing a
yeah.
shift or a stretch there.
Oh yeah. And I mean, we have people here from people have come through here from Colorado, Ethiopia, Los Angeles, Oregon. I mean, they come from all different backgrounds. Not a lot of them rural, typically,
Mm.
but you know, um, and the providers generally are good. They're very compassionate, and I mean that's why we do it, right? Because we love it here, and we love taking care of the underserved populations. But um, patients hate it because they find a provider that they love and then they leave. We hear that. I hear that every time I work at a clinic, and I work locums in these clinics, just due, as to just some being military for one thing. We move around quite a bit,
Mhm.
and just having some family things that I need to still be a mom as well. So it's good. It helps me be flexible.
Mhm. Yeah.
So, if you're wondering, like, well, then why don't you stay at one of these clinics? It's just um, because um, of stability. And anyway, that's another topic.
Yeah,
Um,
so they try a lot of these places it seems like they really try to hold on to people when they can. Do they tend to like are there incentives for staying or what's the draw? Why do providers and nurses and people who come and go, why don't they stay? Why do people tend to leave these areas?
yeah. So a lot of times the workload is insane, as you observed when you were visiting me here.
Mhm.
And it's not as bad for me now since I moved over to the school. Um, but I mean, as anybody knows, from CNA to RN to um, chief resident at UCLA, the charting load is ridiculous. I mean, it's unbelievable. I would see 40 patients a day if I didn't have to manufacture a detailed chart on every single one. But that's the way it is. But the workload can be insane. The frequency of call. When I first got here, I was on call Thursday night, worked Friday, on call Friday night, worked Saturday, on call Saturday night, on call all day Sunday until Monday morning. And then, I mean, it's exhausting, but necessary.
And you were getting calls during those nights too a lot of
Yeah,
the
yeah,
time, it sounded like.
yeah, yeah. And you go in, you get up, you put your scrubs on and go in and address, whatever it is, the
Stitch up
breathing problem, the
whatever
laceration,
happened, yeah.
the chest pain, the GI bleed. I mean, um, actually offered a position in a number of FQHCs, full-time positions, in a number of FQHCs that I've worked in. And I think one challenge for anybody who works as a locums provider in these rural areas is the lack of opportunity for spouses. Um, or my husband, your dad, however we say that, not awkwardly. Um,
I know him.
there,
Yeah.
yeah, I know. There are limited opportunities, job opportunities for him here. I mean, there's literally no equivalent for what he's doing right now in Hana. And
Yeah.
again, the biggest city here is separated by the Hana Highway or the Mokulele
The
uh,
island jumper.
commuter plane.
Yeah.
Yeah, the commuter plane that flies back and forth. Um,
Yeah.
so I think that is one reason we can't retain physicians or providers in these clinics is that not a lot of opportunity for um, spouses and kids as well. I mean, there's no ballet here, there's no soccer. Grace, they really are begging for a soccer program. So I said, well, I know
Mm.
somebody who
I
would probably
know.
like to do a soccer program.
No soccer. Yeah.
There's no stuff that urban families like to have their kids involved in,
Right.
all the things. And so you just kind of have to be satisfied if you have kids to either um, send them to the local school. Some people homeschool, some people board over at Kamehameha schools over on Oahu. Um, and for
Yeah.
high school, they kind of like boarding school. Um,
So just
another
so to
another problem is housing, inadequate housing. Um,
yeah.
can be a problem as well.
So to kind of just recap what and make sure I understand what you're saying. So um a lot of these places, the working at the hospital itself or the clinic itself is overwhelming at times because there isn't a lot of within organization support. And people are expected to maybe do more than they're comfortable with less support than they're comfortable with. But also outside of that organization, a lot of the social infrastructure maybe doesn't exist. So while you might
There's no
have
nightlife.
no nightlife, yeah, it closes down at 7 when the sun goes down, 7 p.m.
5 o'clock.
Yeah.
Yeah.
Yeah, so there maybe isn't a big pool of people to choose from. There's not a lot of competition coming in. So and I know I want to hear more about that, but I'm curious because one of the big things in nursing leadership that we are talking about now is magnet recognition and how these hospitals implement these different initiatives for trying to make these workplaces really excellent. And I think kind of the whole idea with that is if we make this a great workplace, then excellent nurses will and excellent providers and people, it'll sort of draw in this talent because it's such an appealing place to work.
Mhm.
But I think kind of what I'm hearing from what you're saying is that maybe that's harder in areas where like even if the hospital itself is fantastic, if it's right in the middle of nowhere land, then it might be hard to get people to come in. Is that fair to say that that's a challenge?
I think, yeah, it's hard. Again, I think we're talking right now about providers to stay, like you said, the professional isolation is one thing. Professional boundaries are another thing that are
Mm.
difficult because the I think the population of Hana and Byron's is only about
Oh,
2,000 people.
yeah.
So, you constantly have such sweet people coming in, giving you their phone numbers, wanting to play Scrabble at your house, for example. Um, saying, stop by, come over for dinner, so that blurred line of professional boundaries. But um, you do establish strong relationships with your patients, and you have a lot more practice autonomy. Our support staff uh, at Hana Health is outstanding. They're fantastic. We have one nurse who is a local, I believe, probably grew up here and went to nursing school, and the FQHC helped her, paid for her program. So that's another advantage of people who want to further their education and stay in their town. We have another
Hmm.
one who's just fantastic, probably maybe the RN I've ever worked with. And I've told her that, who is a um, dialysis nurse or was a dialysis nurse in Massachusetts and came here because of her sister. So she and her husband live in Hana, and she's a fantastic nurse. And, both of them, um, they're not complainers. I mean, you can tell they just are really, they're so good at what they do, you know, come to work with great attitudes every day. And um, we have dental in our clinic as well, and the dental assistants are like just fantastic. I mean, I have to say, our staff are fantastic. We're tiny, but we're mighty. Um, and I probably completely digressed from your question. You're talking about magnet
No, so I guess that
program.
kind of you did answer my question because I think it's easy to sort of look at these little places and think, well, they're not really pulling in good talent, or they're not, probably they're functioning at a lower a lower level, but sounds like
Yeah.
that's not always the case,
And I've
or
seen
not ever
and
the
I've seen
case.
both. Yeah, no, and I've seen both. I mean, I've seen people, come in and just because they want a job in their town and they're not great and they get fired. They violate HIPAA day after day because they know everybody and they know what's going on in their lives and
Mhm.
they, don't mind talking about it. I haven't
That
really seen a
sounds
lot of,
hard, yeah.
yeah, no, it's hard. Yeah. And, um, like I said, I don't see as much of that here, as I have in some other clinics. But I mean, it's um, a great place for people who want to stay in the town, but want to kind of further their education. And like Lamar has a little community college, that has an RN program. Um, in Hana, our one RN that just graduated had to drive across Hana Highway like 3 times a week to go to
Ooh,
clinicals at the hospital. Yeah, I
that
know.
makes me
So, I
motion
mean,
sick just thinking about it.
I know. Yeah, I know. And I think she's
Yeah.
considering becoming an NP, so she's pretty passionate about what she's doing and serving the community, coming back in the community and serving communities. Yeah.
So would you
Also, the FQHC is just putting it out there. I think there are a couple, there's Nurse Corps, I think it's called, and a couple other loan repayment programs. And that goes from physician all the way down to, I think, probably, MA. There's loan repayment in
wow.
working in underserved areas. So just something
Yeah.
to consider.
Well, I was gonna ask you, do you would you encourage people to come and work in these hospitals and clinics? And it sounds like that's a big incentive. Um, if you come and you stay or do a contract or whatever for some certain amount of time and get some student loan repayment
Yeah,
out of it.
yeah.
But I'd love to hear, just for people who maybe are looking into um working in more remote or rural areas, would you encourage that? Would you say come and try it, or what
100%,
would you say?
100%, 150%. I think it gives you great perspective. And again, as you know, in your clinical practice, and then also kind of following me every now and then in my
All over the place,
uh,
yeah.
practice, yeah, hospital nursing and clinic nursing are two completely different animals. So it just kind of, I think, depends on what you want to do. If you want to continue working in oncology or cardiology or pediatric um, ICU or, something like that, then obviously, hospital nursing is for you. I um, I was frustrated as a floor nurse um, because the thing that I'm really, really passionate about and interested in is diagnosis and treatment. And so not like I was like some genius nurse who knew what was wrong with every patient, but
You
I was
were.
frustrated because, well, I was just frustrated because Um, I really wanted to get to the bottom of what was going on, not just treat the symptoms. And I feel like a lot of times nurses are just kind of delegated to all we can do is carry out the doctor's orders and um, not, um,
Not have as
really
much
get to the bottom of,
autonomy or
yeah. I mean,
yeah.
yeah. And I mean, and don't get me wrong. I mean, the nurses that I have worked with on the floor are just incredible. I'm still in touch with most of them probably, and they're just like fantastic and keep people alive every single day.
Yeah.
But like I said, it's just I think it's really all you want to do. If you're interested in public health and community population health, then these clinics are definitely for you.
It sounds like just from what you've said that these small hospitals in rural settings might be a really good learning environment for people who maybe want to have a little more autonomy or want to be challenged a little more. I mean, I guess there are probably different challenges in any environment you work in, but I think one misconception that I had before kind of looking into this more is that in these rural settings, professional development and learning and training is sort of stagnant, just because there isn't a lot of funding maybe coming in for seminars and with a lot of these big magnet hospitals that you read about, they're always talking about, okay, we sent these nurses to do this training, or we had, these in-service things going on.
Hmm.
And then a lot of these rural areas, they're just fighting to sort of keep afloat some of the time, due to lack of funding or staff
Yeah.
shortages, or, they don't make as much, um, sometimes on care if they're a for-profit hospital because of Medicaid and, um, uninsured populations, that sort of thing. So I guess I digress there too, but it seems like it sort of can be what you make it. Um, I mean, do you feel like you've had opportunities for for learning in
No, and I
your
mean that's for
experience?
me, I think that's more because I'm a locums. I say I'm just a locums, I'm not a permanent um employee, I'm not a permanent um employee, but I have gotten offers from several different places and spoken with other people who are permanent employees and they get a stipend, providers do. I don't know if nurses do if RNs do. But um, they get like a yearly stipend for training. Some of them get, $3,000, $4,000 a year and a week that they can go to a conference or, go get some specialized, like, procedure training or something like that. So that is a nice perk of being a full-time employee as well. Um, and again, I need the flexibility in my life. Again, being a mom and all that, that's why I work locums. Plus, you make a lot more money as a travel um, nurse or as a travel provider. And
So it maybe all kind of works
so I can
works
work
out.
well. So yeah, I can work fewer hours, um, but make the same kind of like full-time money. And it's not all about the money. I just really have fallen in love with public health and rural healthcare. But getting back to what you were saying, um, it is so much about the leadership. And I won't go off on a tangent here, I promise, but it is so much about top down. You gather very, very quickly if your leaders, your CEO, your CMO are, you know, foster a culture of caring and ownership. I think if your clinic becomes just a place where people show up and do their job and leave, it shows. It shows, people complain to each other and they, are always grumbling about anything extra they have to do. And, so that training aspect has to be more than just, hey, you have to complete your
Your
hand
burnout
washing and
module.
HIPAA certification.
Yeah.
Yeah, your HIPAA and your hand washing certification this year is behind. You've got to make sure that you're um, whatever, education. Your lab certification is up to date, Cindy, and it is 100% from the top down. Um, the corporate culture, if you want to call it that, in a clinic, the clinical practice culture. Um, and I've seen it
Yeah.
done fantastically well, and I've seen it done not so well. Um, and it really, like I said, such a difference in just your leadership. I think Dad calls it leadership by walking around, right? And that's so I have
I have
been
heard
to some
that.
clinics
Yeah.
where, I've been to some clinics where the CEO is in the same building and I have never met them or seen them. And I've been to other clinics where the CEO is on the floor and the CMO is on the floor seeing patients and walking around and leaning over the desk, bringing coffee to people and
Yeah.
so
Yeah. And I mean,
it's
I came across an article from the Journal of I think it was the Journal of Nursing Administration from like 1994, where it was breaking down some of the differences in what was effective in specifically rural um clinics who were trying to reach these who were real. I mean, the topic was magnet recognition, but really it's about these hospitals were just trying to become better, right? Um,
mhm.
and it was it was saying visibility in a leader um was one of a kind of a predictor
Yes.
of communication and ability to get everyone aligned with organizational goals and
Yes.
that sort of thing.
Yeah, better than just beating people up over QI measures that haven't been met this month or whatever. Um, it's ownership. I think if, ownership and a culture of caring, obviously every clinic is about caring and patient-centered things, but caring about each other and caring to show up and caring about the mission, 100% comes from the top.
And so I know that you are currently in a course, a leadership um what's the course that
I am.
you're
It
doing
is,
now?
yeah, it is a chief medical officer program through Emory University's School of Business. And it's it prepares you to step into a leadership role as a chief medical officer, CMO, of an organization. We have everybody ranging from a CMO at UCLA, all the way down to me, who works in a little clinic and is not necessarily in a leadership position yet. But
Little old
I
you, yeah, okay,
I
whatever,
know little old
whatever.
me. I went to a clinic one time.
No.
um,
No, so
no,
so you're
but it's been just so valuable already,
yeah.
and I'm only about a week or so into the program, but there are a plethora of programs out there for nurses and providers if you want to move into leadership positions. The possibilities for training are endless.
So as I've seen, and I'm just sort of wrapping up here and just thinking, as I've sort of seen these different experiences that you've had, it seems like you've been drawn again and again to these sort of rural, smaller, underserved. You did a medical mission to Norway to help refugees, and you've helped, in all these different settings. And I know that you have some interest in, especially, with this course that you're taking, you have some interest in eventually um, stepping into more of these leadership and kind of director roles. So I'd like to know if, from everything that you've seen in these different settings with rural and smaller hospitals, specifically, all the challenges that um, these people face that we've talked about and the hospitals face, if you could sort of snap your fingers or have a magic healthcare genie grant you a wish for how to um sort of change healthcare in these areas, what would you do? What are the biggest things that you know that need to be changed or that we can do or that should happen to kind of
Yeah.
make a
Well,
difference in those areas?
we've talked about some of them already. I think a big one is recruiting and retaining providers. That's a big one. And I'm sure that, you know, CEOs and CMOs countrywide are, you know, probably worldwide, continue to work on that. Like, how do we keep these, how do we get somebody good? How do we keep them? So, you know, that would be one, recruit and retain excellent providers who want to stay and form long-term relationships with these patients and community members. You know, another one would be for stable sources of funding. For example, our school-based health program is based on a grant. And so, you know, there's always a little squirm about, will there be a school-based health program next year? Will, you know, my incredible assistant have a job next year? Will I have a job next year? You know, that kind of thing. So, stable funding, it has to do from everything from, you know, staff, people to equipment and all that kind of stuff. Um, uh, Another one is telehealth options. Um, Especially out here, we have people who um, live 45 minutes away from the clinic and don't have a car, and we don't have MedRide here. So, you know, telehealth and the infrastructure for it, you know, even like a place they could go to them that has internet that they could have telehealth appointments, you know, something like that. So if somebody would come and build some sort of little internet centers somewhere where, and you
Yeah.
know, we don't really do telehealth at our clinic right now either. But you know, the infrastructure for telehealth would incredibly expand our ability to take care of the community. Um, you know, access to specialists, we kind of talked about that already. Um, right now we have at this clinic, we have a cardiologist who comes once a month, an eye doctor who comes once a month, a dermatologist who comes, I think, once a month or every other month. So it's tough and they're always full. So they have to wait, you know, patients have to wait. So better access to specialists who want to come as well, to the clinics. So there are a lot of wishes out there. Um, you know, again, we talked about meaningful training and development for staff and mentorship, you know, for staff who want to come. So if there's anyone out there who wants to volunteer their time to go to any rural health or FQHCs and do some training, I'm sure they would take you in a minute.
Mm-hmm. Yeah. Yeah. And so just to bring it back to maybe nursing specifically more to my level. No, not quite at the
Yeah, I
provider
know.
level
I've
yet.
talked a
No.
lot about the provider. Yeah, I've talked a
No,
lot about
it's
the
good.
provider role, but yeah.
It's good to know because I mean that's we're all part of the right, that's the interdisciplinary team where we're all kind of working together um trying to care for our patients. But I know a lot of a nurse's role um is specifically, you know, we do patient care tasks, but we also do a lot of education and a lot of kind of lifestyle um I would say
Yes.
almost like lifestyle management, but not management, but I can't think of the word, but you know, we try to look at a holistic, like, okay, how is this person doing in their environment, right? What's working,
Yes.
what's not working? So, um, I mean, what can a nurse or anyone who's caring for a person holistically, um, in these areas maybe do? Like, what are some actionable things that maybe you see
Mhm.
that these people need or these hospitals need or teams or
Mhm. Um, so getting into the training and certification part, I work with one practice who has a wellness coach who's an RN. She talks to people about lifestyle choices and wellness and dietary things, weight loss, smoking cessation, all that kind of stuff. There are actual certifications that RNs can get um, to be educators in those areas, and probably get paid a little bit more as well. Um, and of course, the area of diabetes, there are opportunities to become a diabetes educator as an RN. Just a program that
Why
you can go through to get certified to do
why
that.
is diabetes? It seems like diabetes is such a not to interrupt, but it seems like diabetes and chronic conditions are such a challenge. I've heard you talk about that a lot in
Mhm.
rural
Ugh, yeah,
areas.
yeah. Well, for example, in Hana, there's really no opportunity for intentional fitness, right? There's not a treadmill to be found. And it's a hard place to walk because there are no sidewalks. And, unless you're out on the water paddling or surfing, which is, obviously not a lot of the population, access to good food and education about good food is limited. A lot of people are on food stamps, SNAP, um, don't make great choices because they want to buy, they need to buy cheap food. Um, um, so the dietary choices are not great. And the Asian Pacific Islander population is, probably has a little bit higher incidence of that. There's not a lot to do, and so eating is a pastime. It's one of the pastimes. And so, we have a lot of overweight, diabetes, a lot of COPD, respiratory syndromes here, because a lot of people smoke and they don't have that peer pressure because everybody smokes. And, it's not like, hey, you're whatever, you're polluting the air. You shouldn't, and so we have a lot of COPD and that kind of stuff here. Again, hypertension, salt. Every Hawaiian food has salt, all the rural meat and potatoes people,
Spam. Oh,
so I think
delicious
it's
spam.
lifestyle. I know. Yeah, spam, right? So, it's lifestyle education, and these people have been eating this way in all the rural areas, not just here in Hana, but these people have been eating this way since their great grandma cooked for them on the farm.
Mhm.
So, it's a hard habit. And like I said, you don't have any societal um, pressures to not to modify those behaviors, I guess is what I'm saying. They're kind of like, yeah,
Yeah.
whatever. Some outside nurse told me that I wasn't supposed to smoke, whatever.
I was gonna say it's probably a city slicker nurse coming in and saying, "Hey, you need
Yeah,
to watch your salt." Probably is not gonna be super
no,
effective.
no.
Yeah. So, sorry to digress there, but so you
Yeah,
can, as a nurse, you can get certifications that'll sort of equip you to address these problems with these.
absolutely. And again, I think it's a top-down thing, to a culture of caring. And the thing with community health is getting it out there, having health fairs. RNs can 100% staff health fairs. Our nurse who is a local, teaches some health things at the school. Um, we have access to free birth control for kids 14, girls 14 and up. We hand out condoms at the high school. They
Mhm.
know that they can confidentially come into the office and into the little clinic and you know, get access to birth control. And um,
Oh.
so there are all kinds of roles in any clinic, not just rural health, FQHC kind of places, but in any clinic, there is so much education that a nurse can do. And again, it's about workload and initiative from the top.
Yeah.
And a nurse can take an initiative too. She can go to the CMO and say, "Hey, to I would love to start a program for whatever, name it, name the health condition, right? I am really passionate about, nutrition. I am really passionate about diabetes control or whatever it is.
Hmm.
And I think they probably will listen if you can come up with funding, and it probably wouldn't take much except some maybe printed material to have an evening session about exercise or whatever. It's just the passion um, more than anything else.
So go to the top leadership and advocate for advocate for something you're passionate about, advocate for change.
Yeah, yeah.
Yeah.
Or go to your supervisor, go to your direct supervisor, and hopefully your supervisor will say, "Hey, I'll take that to whoever, and we'll talk about it."
Yeah.
And don't give up until they let you do it. Put it together, present it to them, and say, "Here's my plan."
Yeah, I know. Just a side note, I've seen some of the my mom is a she doesn't just talk the talk, she walks the walk. She got involved with a food what was it, a food bank down in Lamar, or a farm where they were growing
Food pantry, yeah.
food pantry where they were growing food. She was out there working in the working in the gardens, and she's done all kinds of little side quests for not little side quests, big big things, and started little organizations, started a theater club down in Alabama for kids there to get them out and doing stuff post COVID when things were starting to open up again and people were kind of isolated and depressed and not doing anything. So great advice. Well, thank you so much. I think that's probably a good place to stop. I could probably keep sitting here for another hour and a half, but I know you have places to be and things to do. So, is there anything else that you think is really important to take away from investigations into into rural health and
Well, I think anywhere you land, don't lose your passion. Don't let anybody take away your passion for this. Whether you had passion going in to it, or whether you're just doing it because you it
need a
needed
job,
something to do, which
need a job.
I know nurses who are like, well, I didn't really know what else to do, so I went into nursing. But man, grab that passion and run with it. There is so much you can do. You can change the world as a nurse. You don't have to be the chief resident at Johns Hopkins. You can be an RN and do the most amazing things for people. Go out there and change the world and do whatever you have to do to hang on to your passion. And it doesn't have to just be, oh, my passion is nursing, but your passion is people. And that's why you're doing this, because your passion is people. So don't lose that.
Good good advice. You heard it here. You heard it here first. No. All right. Well, thank you so much.
Thanks so much for your time.
Well, thank you for your time. I'm sure I'll talk to you again soon.
You
Maybe next
better.
year. All right.